Today we're going to examine a really persistent problem in clinical diagnostics, the search for a truly universal biomarker for inflammation. We'll be looking at a novel solution proposed in a 2021 paper from the journal Applied Sciences that focuses on creating a marker that is completely independent of a patient's age.
So the whole challenge really begins with a hidden threat, something called subclinical inflammation. You can think of it as a low-grade, simmering inflammatory state that doesn't produce any obvious symptoms. The problem is, it can dramatically elevate the risk of complications, especially after aseptic procedures like those you see in maxillofacial surgery. And this brings us right to the central question that's driving all this research. How can clinicians reliably detect this concealed inflammation before an operation? And, maybe more importantly, how can they set up a consistent standard when they're assessing patients who might be decades apart in age?
To answer that, we first really need to understand the limitations of our existing diagnostic tools, especially when it comes to predicting these kinds of surgical complications.
For years, clinicians have been relying on markers like hyperleukocytosis, an elevated white blood cell count, and C-reactive protein, or CRP. Now, while CRP is an excellent indicator of acute phase reactions, the research shows it's just less effective at capturing the nuances of chronic, low-grade inflammation, which is the very condition we need to identify here.
This need for a more sensitive tool led researchers to a biomarker known as SUPAR. But this powerful tool came with one significant built-in flaw. So what is SUPAR? Well, it stands for Soluble Urokinase-type Plasminogen Activator Receptor. It's an ultra-sensitive marker that reflects the body's level of low-grade inflammation. Its concentration is an independent predictor for morbidity and mortality across a whole range of diseases, which makes it a far more sensitive measure than our traditional inflammatory markers.
So here's the crucial point. SUPAR has these remarkable strengths, right? It's ultra-sensitive, it's predictive, and it reflects the chronic conditions that other markers miss. But it has one critical, confounding flaw. Its serum level is directly and significantly correlated with the patient's age.
And this age dependency isn't some minor issue. It's a fundamental barrier to its widespread clinical use. Let's actually take a look at the data to see exactly why that is. Okay, now what's really interesting here is this chart in the top left. It's a simple regression plot of raw SUPAR levels against patient age from the study group. You can see it clear as day. The regression line trends upwards. As age goes up, so does the SUPAR level. And with a p-value of less than 0.0001, this confirms a highly significant positive correlation. This makes it just impossible to establish a single universal standard. The researchers first tried some simple mathematical corrections. What if we just divide the SUPAR level by the patient's age, or even age squared? Well, it turns out that didn't remove the age dependency. In fact, these methods just inverted the correlation, and, more importantly, they distorted the fundamental statistical properties of the data, which destroyed its normal distribution.
So, a much more sophisticated mathematical approach was needed. And this brings us to the development of the Index of Body Inflammation, or IBI.
The objective was twofold, and it was very precise. First, the new formula had to completely eliminate the correlation with age. Second, it had to preserve the original Gaussian or normal distribution of the raw SUPAR data. That was key to maintaining its statistical integrity and its clinical relevance.
And here it is, the solution the researchers developed. The index of body inflammation is calculated as the square root of the SUPAR level squared, all divided by the base 10 logarithm of the patient's age. Using the logarithm of age in the denominator provides a much weaker nonlinear correction, and that turned out to be the key to neutralizing age's influence without distorting the underlying data structure.
So the big question is, does this formula actually achieve both of those objectives? Let's move on to the validation data and see how this new index performs. Here we see the definitive proof. This is the regression plot for the new IBI against patient age, shown in the bottom right. The regression line is, well, it's essentially horizontal, and that p-value of 0.4861 confirms there is no statistically significant correlation whatsoever. So the first objective, age independence, has been achieved.
Now what about that second objective? This density trace compares the distribution of the raw SUPAR data, that's in red, with the distribution of the calculated IBI in blue. As you can see, the two curves almost perfectly overlap. A Kolmogorov-Smirnov test confirmed the distributions are statistically identical. So what does that mean? It means the IBI is not only age-independent, but it also preserves the essential statistical properties of the original biomarker.
So, with a validated, age-independent index, we can now consider the really profound implications this has for preoperative patient screening and for risk stratification.
The clinical applications here are pretty significant. The IBI provides a universal screening standard for subclinical inflammation that is just as valid for a 20-year-old as it is for a 60-year-old. This allows for much more accurate pre-surgical risk assessment, for direct comparison between different patient groups, and ultimately, it enhances surgical safety by identifying those clinically silent patients who are at a higher risk of complications.
The authors of the paper really summarize it best. They said that by creating an ultra-sensitive marker of inflammation that is truly independent of age, clinicians can have much greater confidence in preparing their patients for surgery, knowing they have a reliable tool to detect these hidden risks.
And this leads us to a final, forward-looking question. Now that this confounding factor of age has been mathematically resolved, what new frontiers in diagnostics and preventative medicine will open up for this powerful and now newly standardized biomarker?